to assist the viewing audience in managing their health. The program begins with diabetes, which is divided into Part 1, Part 2, and Part 3. I'd like to take this opportunity to acknowledge Franklin Hospital Center, Rosedale Lions Club, North American Airlines, Pathmark Foods, and Geico Direct for their demonstration of their continued commitment to community service.
Hello, I'm Linda Rodriguez, Assistant Executive Director for External Affairs at Franklin Hospital Medical Center. Here at Franklin, our team of doctors, nurses, and healthcare professionals is dedicated to helping our community maintain its good health, and also working with them to deal with any medical conditions they do have. That is why we're so pleased to be part of this community education program on diabetes. One member of our administration team, whom I would like to introduce you to, is Joseph Lamantia, Deputy Executive Director.
Community outreach is one of the cornerstones of Franklin Hospital Medical Center's mission. With the number of new diabetes diagnoses increasing, it is especially important to open a dialogue with our community on how to recognize and treat this condition. If community members are given the information and tools they need, they can become effective partners in managing their diabetes. For this program, we have assembled a panel of experts to address various aspects of care. First, Dr. Pat Corcoran, Director of Physical Medicine and Rehabilitation, and also the Medical Director of Franklin's Extended Care Division. Dr. Ellen Miller, an internist specializing in endocrinology, and the Assistant Medical Director of Franklin Hospital. They will discuss the physiological aspects of diabetes, guidelines for prevention, and detection and treatment modalities. To discuss the impact of exercise on diabetes, you will hear from Angela D'Amedeo, Physical Therapy Assistant in our Rehab Medicine Department.
I'm about to show you some of the exercises that we would incorporate in a physical therapy routine for patients that I would see who maybe have diabetes. These patients have special needs. Maybe their blood sugar levels aren't always under control, and we would educate them on what they need to do to get into a routine where they would be able to do these activities every day and incorporate it into their lifestyle. Exercise has to be a lifestyle, part of your lifestyle. You have to have a conscious effort every day to do these things. And little by little and little increments, you'll be surprised at how much it's going to affect you and how it's going to make you feel healthier, how it will affect your glucose levels and make you feel stronger and have overall well-being. There are general stretches that it's a good idea to do prior to doing any type of physical activity. You want to warm your body up, warm the muscles up. If you start right off the bat going from full-blown, from doing nothing to running out and doing all kinds of activities, you'll wind up causing muscle strains, pulls, and you could actually even cause maybe having a heart attack during your exercise. Say if you're going to go walking, you want to start a walking exercise program. What you need to do is just start increasing your steps during the course of the day. Taking little steps up and down and just warming up your muscles, because this is the motion that you're going to be doing. Okay? Once your muscles are nice and warm, now you're going to actually start stretching them out. You can do them in a lot of different ways. You could even do it sitting down, lying down, up against the wall, whichever is most comfortable for you. You want to stretch the muscles in the back of your legs, your gastrocs, and your Achilles, okay? Because these are muscles that you're going to be using when you're stepping. So what you can do is you flex your toes up and point them down. Flex them up and point them down. You don't necessarily, you shouldn't lock your knee. You want to keep a soft knee because you don't want to cause other injury. Okay? You can start by reaching forward and coming back. Okay, reaching forward. Reach from the hips. Don't arch your back. You don't want to round your back because it's putting too much pressure. So you want to reach forward. Hold it. Never bounce. You never want to bounce because that Well, your muscles will say, well, what am I doing? Am I stretching? Am I coming straight? Nice prolonged count for about 20 if you can hold it. And then if you can just go a little bit further and reach a little bit more. Make sure you breathe nice and comfortably, and then bring yourself back up. Okay? That's just starting out slow. That's if you want to do it like in a sitting down position. You can also do it standing up. I'm just going to show you another way that you can possibly stretch out. Doing it on the mat or in bed, that's a good way before you get out of bed to get started, to just kind of warm your muscles up a little bit. But say if you're going to go out for a walk and you want to stretch out and warm up a little bit, this is another way that you can use your stairs at home. Okay? Put your feet up on a step and make sure you keep them in straight alignment. You want your toes pointing forward and your back foot is also pointing forward. Forward, lunge forward, okay? You never want your knee to go in front of your toes. You don't want that to be putting too much pressure. So the knee should be before the toes, and the back leg should be with the heel down. If you're doing it like this, you're not getting a good stretch. So make sure that you have your heel down, and you'll be feeling it in your Achilles and in your calf muscles over here. Okay? Keep your hips straight, your back straight, and lean forward. Hold it for about a count of 10 to 20. And then you can push yourself back using your front leg. Okay, and you should repeat that a couple of times. So you're going to pull forward and back. Okay? And that's for the lower legs. Another way that you can possibly stretch out is putting your toes up on the step, dropping your heels down, and again, keep soft knees. You don't want to lock your knees. You just want to stretch. You want to stretch the muscles in the bottom of your leg. And that's another way that you can stretch. Okay, when you go to get up, roll yourself up. Don't just straighten out your legs and pop your back up. That's how you would exercise or stretch your lower part of your legs. Now the next thing that you want to do is you're going to stretch the front of your legs in here. And a way that you can do that is by holding your ankle and just bringing your foot closer to your rear end. Okay? When you start out, you may not be able to do it this well and get it this high up. So, something that you can do, put your foot on the step and lower yourself down. Okay? And by doing that, you're stretching out the muscle in here. There are a lot of different ways that you can stretch out. You want to find the type of stretch that gives you the best amount of stretch and has the most amount of comfort for you. Because if you do something and you overstretch, you're not going to keep this up. And that's the key to changing your lifestyle, is to keep up the exercise. Keep it up until you start to feel the benefits. You reap the rewards of increased range of motion, increased flexibility, and increased muscle strength. There are a lot more different kinds of stretching activities that you can do. Those are just a very, very small sampling of the different muscles that you can be stretching. You still need to stretch your low back. You can stretch your arms and your shoulders, especially older people. Shoulders and rotator cuff injuries are very prominent. There's a lot of different types of activities that you can do. You can start using weights. You can use Theraband, and this is a free weight. We also have something like this, which is a dumbbell. Okay, and these are also things that you can use in your exercise regimen. To a store or sporting goods store and spend a lot of money on these types of things. You could make them on your own. I had a patient once where I told her just to lift up a 5-gallon jug of oil, and she was doing her arm exercises using the jug of oil. So if you're going to start out with and you're just trying to look at little things that you can incorporate this into your day, as you're cooking your dinner, pick up the jug of oil and lift it up and down. And now you're working your biceps. So there's a lot of ways that you can start doing exercises without even consciously, spending a lot of money and buying a lot of different type of equipment. We also have something that's called a Theraband. The Theraband is another type of exercise tool that we use in physical therapy. And this can be used at home. We give this for home exercise programs quite often. What it is just a piece of elastic, and it comes in different grades of resistance. The green is a little bit more resistant than the red. And you can use this to do your stretching also and your strengthening. By holding onto this and bringing your arms out and in, you're exercising your shoulders, internal and external rotation, out and in. Okay? That's just something that you can do, but if you don't have access to this, you can use other things. You can use a towel, roll it up, and you can practice this way too. So there's a lot of different things that you can use just in your own house that's going to help you incorporate a little bit more activity, because that's the name of the game, is by increasing your level of physical activity, you'll cause weight reduction and you'll increase your body's movement and circulation. By doing that, you're going to utilize a lot more of your body's sugar levels, which will help decrease your glucose. There's a lot of things that you have to be ready for when you decide to make a conscious effort to change your lifestyle. You need to be aware of when is a good time to exercise and when is not a good time to exercise. The level of intensity that you should be exercising. A low intensity workout would be, say, you can exercise, breathe, and carry on a conversation without any problem at all. A moderate kind of an exercise would be that you can exercise and have a conversation, but it becomes just a little bit more difficult to carry on a conversation. An example of that would be, say, trying to walk a mile in 15 to 20 minutes. And if you're not that physically active, that's going to be a stretch for you. So by the end of the 15 or 20 minutes, you should be breathing a little bit harder, but not out of breath. And a high intensity workout would be something where you're going to do a lot of, your breathing will become more labored, and you won't be able to carry on a conversation. And an example of that could be like running a 6-minute mile. That's high intensity. Don't aim for high intensity right away. You want to start small. You want to set small, short goals for yourself, achievable goals, because then you'll keep yourself on target. Then you'll want to do the exercise because you're starting to feel a little bit better. You're getting the results of your blood pressure will be coming down. You're losing weight. Clothes are fitting you better, and you just have overall general well-being. It's a good idea to avoid exercising 1 to 2 hours after you have a meal. Exercise increases your sugar and energy usage, and you could actually make your sugar levels drop very, very much. So wait until about an hour and a half, 2 hours after you've finished having a meal before you start your exercise activities. And also, if you're planning on doing, like, say, exercising your legs, bicycling or jogging or going for a long walk, it would be a good idea to avoid injecting, if you have type 1 diabetes, injecting your thigh muscle with your insulin injection, because the exercise increases the absorption of the insulin and makes it work much faster. Instead of using your thigh as your injection site, it might be a better idea to use the abdomen as a different site for that particular day. And alternate. If you're going to, you should vary your exercise regimen. One day you may exercise your legs, the next day you're going to do something else. Variety is going to keep you active and keep you more involved in maintaining your exercise regimen. If one day you decide to do bicycling, the next day, say, go rowing or do a dancer-size class or swimmer-size class, because variety is the spice of life, and if you keep variety in your schedule, it won't become boring. Also, by joining an exercise class like a Tai Chi, or you're going to meet a lot of different people, and having a peer who is doing the exercises with you is very important, because the days that you feel like doing absolutely nothing is the day that they're going to call you up and say, get out of bed and come on, we have an exercise class to go to. So they'll help keep you on target. And that's really so important, is that you, once you decide and make the decision that you're going to start an exercise regimen, that you keep it up and make it become part of your lifestyle, because that's how you affect change, is by keeping it up, doing it for a long time. It's important to make sure that you wear the right type of clothing when you're exercising. In the summer, you're going to wear lightweight clothes that allow your skin to breathe. And in the winter, you have to be very, very careful about protecting your extremities from frostbite. You want to make sure that your hands and your feet are kept nice and warm, and also that you wear the proper type of shoes. If you're going to go and play basketball, well, don't wear tennis shoes. You want to make sure that you have the proper support. And the reason why that's so important is people who have diabetes have decreased sensation in their extremities and decreased circulation. And what you want to make sure is that any type of redness or blisters or cracks in the skin, you want to look at your feet and see if the shoe is rubbing on a certain area, because a blister, although it looks like very, nothing bad, if it's not taken care of and caught right away, with diabetes, it can become a very serious problem.
Good morning, Ms. Smith. How are you doing today?
Fine, and you?
Okay. Any questions, problems, or concerns that you'd like to discuss with me today?
I'm just here for my yearly checkup.
Okay. Have you been exercising? We had talked about you starting an exercise program at least 3-4 times a week.
Okay.
About 15-20 minutes a day.
Okay.
Even if it means you just parking at the far end of the parking lot and walking that extra distance, it definitely helps a lot. Okay?
Alrighty.
Alrighty. Good
Thank
seeing you today.
Alrighty.
Jane Prokopowicz, Chief Clinical Dietitian, will discuss the part nutrition plays in preventing and controlling diabetes.
My name is Jane Prokopowicz. I'm the Chief Clinical Dietitian at Franklin Hospital Medical Center, and I'm here today to discuss healthy eating habits for weight loss and for diabetes. Learning meal planning can help control your blood sugar levels. You don't need to purchase special or diet foods. The foods that you purchase for your family are just as healthy for you as they are for your families. If you need to lose weight, that can help control your blood sugar levels, and it can be done by using the same guidelines as we'll discuss now. The basic guidelines are basically to eat a wide variety of foods, try and eat the same time every day, space your meals out with snacks, eat meals at regular times, eat the same amount of food every day, and try not to skip any meals. If you skip meals, your blood sugar may fluctuate up and down, and you also may be just so hungry for the next meal that you overindulge. In planning your meals, there are 3 basic food groups that will help control your blood sugar. The first one is protein. Protein is found in meats, dairy, milk. It helps to build bones, muscles, and it also helps with enzymes and different processes of the body. The second group is fat. It's found in oils, mayonnaise, margarines. It's found in sweets. A lot of convenience foods have fats in it. It's a very concentrated source of calories. But it also helps in trying to control your blood sugar, as it delays the emptying of the stomach, so the sugars aren't absorbed as quickly as it would if it was on an empty stomach. Carbohydrates provide energy. Starches, grains, fruits, milks, sugars, desserts. These foods have a direct effect on your blood sugar. The total amount of carbohydrates that you eat during the day has more of an effect on your blood sugar than the type. Complex carbohydrates, high fiber, whole grains, those are called starches when they're digested and absorbed into the blood as sugars. Fiber, protein, and fat slows down the digestion and absorption of the sugar, so your blood sugar remains more stable. It gradually increases as opposed to having a very high increase. Your meal planning can be done 2 ways. You can either count carbohydrates, or you can use an exchange list. The exchange list categorizes foods into different groups. So you have a starch and grain list, a protein list or a meat list, a fat list, a fruits and vegetable list, and a milk list. These lists all contain similar foods that have similar amounts of protein, fat, and carbohydrates. The exchange list can diabetic association. When you're doing your meal planning, you want to try and include all types of food in your meal. You want to have protein, you want to have fruits, vegetables, as well as complex carbohydrates, whole wheat grains. An important part of meal planning is learning to read labels. Labels gives you all kinds of information on how much fat, calories, protein, and starch, as well as sugars are in each product. You need to be careful when you're reading labels. This bag of chips appears to be an individual portion, but when you read the label, this actually contains 2.5 portions of chips. So when you're looking at the nutritional label on here, it's giving the information for one bag, for one portion. So 160 calories is one portion, which would make this bag of chips well over 300 calories. To determine how this food may fit into your daily meal plan, pay close attention to the portion size on the food label, as it may be different from that used in the diabetic exchange list. Just to give a rule of thumb, this apple is a medium-sized piece of fruit, and it fits in my palm. That's a medium-sized piece of fruit. The palm of your hand can hold 1 to 2 ounces of nuts or pretzels. Your thumb is basically 1 ounce of meat or cheese, and your fingertip is about a teaspoon. So some basic nutritional guidelines with people for diabetes are to develop a routine. Eat meals at the same time every day. Space meals no more than 4.5 to 5 hours apart when you're awake, and try not to skip meals. Snack if necessary. Check your blood sugars. Good snacks are cucumbers, celery, lettuce, radishes, foods that have a little bit of calories. Eat 3 balanced meals a day. Have some protein, fruit, vegetables, and carbohydrates in each meal. Control your portion sizes. Remember to read the labels and limit second helpings. Eat a wide variety of foods. Limit lean meats and substitute fish and poultry. Limit the amount of starchy foods to 1 or 2 servings per day. Starchy foods include things like corn, rice, winter squash, biscuits, dry cereals, rolls, peas, things that are of starchy nature. Limit fruits to 1 small piece, lunch and supper. Try not to drink juice. Juice is absorbed very quickly and can have drastic effects on your blood sugar levels. Have milk, approximately 2 cups of skim milk or fat-free milk a day, and try and avoid high-fat foods and oils like bacon and sausages and cold cuts. Increase the use of high-fiber foods. Read cereals for breakfast. Eat high-fiber cereals. Low sugar, high fiber will help control blood sugar. Use sugar substitutes like Equal or Sweet and Low. Avoid the use of sugar. Avoid alcohol. These interact with your medication. Limit desserts. You can have desserts, but limit them. Portion control. When you go out to eat, don't supersize in fast food restaurants. Get the small burgers. Use the nutritional information that's available at these restaurants. It can help determine how these foods can fit into your daily meal plan. Some of those big sandwiches have 6 to 8 breads in one sandwich because the rolls are so large, and have so much fat in it that one hamburger could be almost 1,000 calories. Limit low-calorie foods to 20 calories per meal. Things like ketchup, low-sugar jams, and jelly. Use sugar-free items as much as desired. That's sugar-free sodas and candies. Any meat and vegetable made without glaze or syrup is okay, But if you're having something that's honey glazed, you can have a little bit, just limit your portions. It's important to achieve and maintain a desirable weight. Consult with your physician or your registered dietitian. Use less salt. Eat foods high in fiber, approximately 20 to 30 grams of fiber per day. Some major sources of fiber are fruit and unpeeled vegetables, beans, legumes, whole wheat grains and breads, and cereals. Eat 2 servings of fruits a day, preferably at lunch and dinner. Eat 4 to 6 servings of vegetables a day. Other carbohydrate sources, such as breads, pasta, rice, can be eaten 2 to 3 times per day, but eat them with a mixed meal of protein and vegetables. When you're reading food labels, some other names for sugars that could be listed are glucose, dextrose, corn syrup, fructose or fruit sugar, molasses, lactose, honey, raw honey, inverted sugar, maltose, malted syrup, dextrin, sugar alcohol, sorbitol, mannitol, and xylitol. These are all different names for sugars, and more than one could be listed. Check the grams of sugar in each product and the total grams of carbohydrate in each product that you're choosing to see how it can fit into your menu plan. For further information, please call your physician. You can also call the American Diabetes Association and the American Dietetic Association. Thank you.
We hope you find this program both interesting and informative. Please know that we at Franklin are always here to answer any questions you provide you with the finest medical services available. Community outreach is one of the cornerstones of Franklin Hospital Medical Center's mission. With the number of new diabetes diagnoses increasing, it is especially important to open a dialogue with our community on how to recognize and treat this condition. If community members are given the information and tools they need, they can become effective partners in managing their diabetes. For this program, we have assembled a panel of experts to address various aspects of care. Dr. Pat Corcoran, Director of Physical Medicine and Rehabilitation, and also the medical director of Franklin's Extended Care Division, Dr. Ellen Miller, an internist specializing in endocrinology, and the assistant medical director of Franklin Hospital. They will discuss the physiological aspects of diabetes, guidelines for prevention, and detection and treatment modalities.
Hi, I'm Dr. Ellen Miller. I am the Vice President of Academic Affairs and the Assistant Medical Director at Franklin Hospital Medical Center, and I'm in private practice in internal medicine and endocrinology.
Hello, I'm Dr. Patrick Corcoran. I'm Director of Rehabilitation in the Franklin Hospital Medical Center and also the Medical Director of the Extended Care Division, which includes a subacute rehabilitation program. Dr. Miller, perhaps you could say a few words about the problems of diabetes and being overweight?
Absolutely, Dr. Corcoran. Diabetes is a disease that often leads to devastating clinical and economic consequences. Perhaps as many as 16 million Americans, the majority of them over the age of 40, have diabetes. In addition, another 6 million probably have the disease and have not yet been diagnosed. Diabetes can lead to terrible consequences. It can increase the risk of patients getting heart disease, stroke, blindness, kidney failure, and even amputations. It's the 6th leading cause of death by disease in the United States and costs the United States economy over $100 billion annually to treat the disease and its complications. Several recent studies, however, suggest that tight control of the blood glucose levels in patients with diabetes may help to prevent some of these long-term devastating consequences and improve the patient's quality of life.
Wow. You know, one of the more problematic numbers that I've been hearing is about diabetes in children. Back when you and I were growing up in the 1960s,
Back in the dark ages?
Only about 4% of kids were overweight. If you
really?
look around today, that's about 1 in 25 kids. Today, about 1 in 7 kids, about 14% of children are overweight.
What do you think? What do you attribute that to?
Oh, I know just looking at my own kids and comparing the way they're growing up right now to when you and I were growing up. Kids are home a lot more. They're not as active. Video games, TV, it's been shown that kids
your children watch the TV all day too?
Yeah, well, kids watch more TV and play more video games and little handheld games, and they spend more time on that than doing anything else.
Oh, plus, wait, the computer games also.
The computer games also. But when you think about TV, and they're sitting there watching TV, what are they really doing?
And what are they doing while they're watching TV?
They're watching advertisements for not nutritional snacks, not for bananas and whole grain oats and stuff like that. They're watching advertisements for candies, for other things. High fat, high sugar content, high calorie content. This is what they're doing. They're not getting out there playing ball. Too often they're staying inside. And it's really leading to a very large increase in the number of kids that are overweight. And overweight, as you know, leads to the prevalence, which is the number of cases, has actually tripled in the United States in the last 30 years or so. The CDC, that's the Centers for Disease Control in the United States, is estimating that about 1 in 3 kids born today will come down with diabetes in the future. 1 in 3 children will develop diabetes.
Do you think more children are developing diabetes, or do you think that we're just getting better at diagnosing the diabetes?
No, more children are developing diabetes. It's estimated that about 20 million people in the United States have, what do they call it, impaired glucose tolerance?
We used to call this pre-diabetes or early diabetes, maybe even latent diabetes. And what it is it's the patients have elevated blood glucose levels, and they just haven't hit the levels that we consider to be diabetes yet, but they're not normal blood glucose levels. And it's really important that we pick these people up at an early stage when it's still possible to correct the situation, because these people can also develop the long-term complications that we see in the patients with the overt diabetes.
Diabetes is often diagnosed about 4 to 7 years after the true
After
onset.
the patients develop these first symptoms or this impaired glucose tolerance, very often within 4 to 7 years after that, we see them developing full-blown diabetes.
Right. Some of the complications, the ones that I see on the rehabilitation unit, the patients that I see, I guess just starting at the top and going down, the eyes.
It's not just the typical thing, as I had mentioned earlier, about the blindness, which is when the diabetes is affecting the tiny blood vessels in the back of the eye and the retina. In addition, it also affects the lens in the front of the eye and can increase the risk of developing cataracts. Mm-hmm. And so that impairs their vision early on, the cataracts, and then later on as the diabetes progresses and the vascular disease changes progress, we start seeing changes in the retina, and these, if they're not corrected early and treated early, they can lead to blindness.
What we also see, though, is, you mentioned the cataracts, the reading, so if somebody enjoys reading, somebody enjoys sewing, knitting, things like that, and they can no longer see that well.
Absolutely.
They can't drive at night, they lose the ability.
The night vision is devastating to them, the loss of the night vision also.
Yeah, confined at night. Oh, and people can't go out, do the things.
It's a dramatic change in their quality of life is what they're seeing early on.
In the mouth, I know there's more dental problems just with...
They increase the risk of gum infections. When the sugar is really out of control, they secrete the sugar in all of their body secretions. And it's in the saliva, and with the increased sugar that's in the level in the saliva, it increases the risk of them developing thrush in the mouth, which is a yeast infection in the mouth. They see it sometimes as a white coating on the tongue. And this is very commonly seen in diabetics.
I've dealt with people who have had it in the back of the throat.
Oh, absolutely. They can even see it in the early part of the esophagus as well.
Very painful. It can be very painful.
Very painful swallowing.
Yeah. Thinking more diffusely now, the blood supply.
The diabetes, the elevated levels of blood glucose that are in the bloodstream causes problems in the lining of the blood vessels. And this leads to problems in the blood vessels all over the body. It can narrow the blood vessels everywhere from if you start at the top, at the brain, and it can cause that, increasing the risk of decreasing blood supply to the nerve cells in the brain and causing a stroke. It can narrow the blood vessels in the carotid arteries in the neck, which can it can also cause clots in the carotid artery in the neck that can break off and go to the brain and also cause a stroke. It narrows the blood vessels as well in the heart, and increasing the risk of developing heart attacks. And the same thing happens in the kidneys. And as I mentioned earlier, these patients are at increased risk for decreased renal function, decreased kidney function, and developing kidney failure in the future.
Winding up on dialysis.
Absolutely. And then going down into the legs, they also decrease their blood supply to their legs. And this is when we see the devastating problems with non-healing in the feet and the lower legs, because the blood supply is not good to get there, and they don't heal, and they end up with infections, gangrene, and then eventually, unfortunately, amputations of the toes, the feet,
One of the reasons why they get it because of the blood supply, but it also affects the nervous system, from what I've seen.
Absolutely. There is an effect on the nervous system. The conduction down the nerve endings is slowed down. And that really is probably the origin of the problems with the feet. Yeah. They don't feel the pain in the bottom of their feet. If they walk barefoot and they get a sore on the bottom of the foot, that is the beginning of this ulcer, and then it doesn't heal because of the blood supply. So that's why I'm sure you tell the patients the same thing I
was just going to say.
No bare feet, no walking barefoot, and certainly they always must wear socks. I like tennis socks inside their sneakers. They have to wear socks inside sneakers and shoes. Don't get those pressure ulcers inside.
Good fitting shoes or sneakers. Then there's one more body system that I'm thinking of. The immune system gets compromised, which is, as you were saying before, you get the thrush in the mouth. But it all comes together. You mentioned a foot ulcer. You mentioned a foot ulcer because, in my mind, that's where all of these problems come together, in that person loses some sensation in the foot, the bottom of their foot, between their toes. They develop some dry skin down there. They get a small crack. They don't feel it, though.
Absolutely.
So they don't know they have it.
And then they've got the bacteria can grow there. And as you mentioned, the immune system is not as good. They don't fight the infection as well, and so that can just keep on propagating and
their vision is poor. So when they look, they don't even see it, even though they have an idea that something's there.
We make sure that these patients see a podiatrist on a regular basis.
Absolutely.
I don't want my diabetics even trying to cut their toenails themselves. I want them to go to a podiatrist and have it done professionally. So there's not, even if they just get a small cut from cutting their toenails or doing something with their cuticles, that can develop into a devastating infection.
It's amazing, though, because sometimes a person has an amputation, something going on in the other leg. I think it's very difficult for somebody with diabetes to appreciate the fact that whatever happened in one leg can still happen in the other leg.
It's not like they have a chance of getting something, and once they get it, they're done with it.
They're done with it. No,
it comes back to haunt them on the other side also.
It's a real difficult issue for somebody to accept that they have to keep an eye on all of these things. They have to follow their diet. They have to take in the medications. It's a
Right.
very difficult. It's easy to say being a doctor. It's easy for me to tell somebody all these things, but I also appreciate how difficult it must be.
Unfortunately, when we make the diagnosis in a child, okay, the parents are watching out for them at that point. The mother is making sure they're taking their insulin if they require it, is watching their diet, is preparing their meals, and pretty much watching them closely. What happens when they hit adolescence? These teenagers are just like all the other teenagers out there, and they're going to rebel. And one thing is they start slipping with their medication, they start eating the wrong foods. All their friends are going out for junk food, so they want to eat the junk food as well. They want to maybe drink a little bit, and this is a real problem. And we have to stress the importance of them doing the right thing all the time, including in that adolescent time, because when they come in 10 years later and now their kidneys are starting to fail or they're starting to get those ulcers on their legs, it may be a little bit too late to reverse all those changes that have already occurred.
Right. Some of them perhaps are reversible, but unfortunately, too many of them may not be. And that's eventually when they do wind up on our rehabilitation unit. Unfortunately, some of the things...
Or on kidney dialysis, unfortunately, waiting for a kidney transplant.
There was a study called Diabetes in America where they actually looked at disabilities. Somebody has a disability, what they've actually done is lost an ability, lost a freedom to do something. People with diabetes, if you compare them to somebody in their own age bracket, people with diabetes 2 to 3 times more often have difficulty with walking, difficulty getting to walk from here to there without even thinking about it. 2 to 3 times more problems with that. 2 to 3 times more problems with just taking care of themselves on a daily basis. If you have difficulty walking from here to there, you're going to have difficulty getting into the bathroom, getting on and off the toilet.
In and out of the bathtub.
Yeah, well, that's a biggie. There's a lot of falls there, and one thing leads to another. Just taking care of themselves. They lose more time at work, which also reflects into losing time with family, because if you're at the doctor's in the late evening hours, if you wind up in a hospital more often...
Actually, the hospitalization is the worst part.
The hospitalization is the worst part, and as you mentioned earlier, with the foot ulcer, that's probably the leading cause of hospitalization for people with diabetes.
Absolutely.
Problems with their feet.
And then after they leave the hospital, they're going to be into rehab facilities.
The rehab facility,
sometimes long-term care facilities,
which can be months to years to a lifetime. And there is an increased rate of people going into a long-term care facility, coming home again perhaps from a rehabilitation unit or staying related to diabetes.
Absolutely.
So if we can kind of steer them away from that'd be great. A lot of doctors until recently haven't even been convinced that if you control blood sugar,
that it would prevent the long-term complications.
Yeah,
I think that's really been pretty much proven that there is a definite relationship. It's been proven very well in numerous studies. One of them in the United Kingdom that's very famous, and they really looked at controlling blood glucose levels tightly, keeping them as close to normal as possible. By watching diet and encouraging exercise, and then they looked with various medications and added to the diet control, and they found an absolute direct relationship between the tight control of the blood glucose, which they actually measured not just from the glucose level. They measured it on the hemoglobin A1C level.
The A1C.
I like to call that the lie detector test for diabetics.
Yeah.
How many diabetics come into the doctor's office, they know they have an appointment, and they starve themselves for 3 days before they come in. They come in, that glucose is perfect. Their cholesterol is perfect, their triglycerides are perfect. But now we have a test where we can check their sugar going back 3 months, and we can get an average glucose level for those 3 months, and that is really where the correlation lies. That if we can get that hemoglobin A1C level that reflects the average glucose level for the last 90 days into the normal range, those are the patients that are going to prevent these long-term events that we've been talking about. Diabetes is the most common endocrine disorder that we treat in the United States right now, and there are 2 types of diabetes. The first type of diabetes we now call type 1 diabetes. This is the one that we used to call juvenile onset diabetes or insulin-dependent diabetes.
Kids with get this.
And this is what we generally see the children
Right.
developing. This is the most common thing that the children develop. It is thought to be due to an autoimmune condition, which means that the body's immune system is not recognizing the insulin-producing cells in the pancreas as that they're supposed to be there, okay? And so what it does is it tries to destroy them. And what happens is they destroy these insulin-producing cells in the pancreas so that they're no longer able to produce insulin. And these people with type 1 diabetes have an absence, essentially, of insulin. These people need insulin to live, okay? And no amount of diet or exercise control is going to bring that diabetes under control. They must be given insulin, okay? The second type of diabetes is called type 2 diabetes, very creative.
That's the adult onset.
That is the adult onset. That's the one we used to call adult onset or maturity onset diabetes, or even they've called it non-insulin dependent diabetes, which is a little bit of a misnomer. These people do actually require insulin for their total control. But in general, these are the types of people that generally come in overweight, and they have a genetic predisposition towards this type of diabetes. So there may be someone, a mother or a grandmother might have had this diabetes in the past. And we first try to aggressively treat these patients with diet and exercise. And then if necessary, the next step we go to is to add what we call an oral agent. We add a pill to try to increase their insulin production, their own insulin production from the pancreas, or we use a pill that might improve the ability of insulin to do its job on the other tissues of the body, or we use a combination of these medications. And then the last step we go to in these people is insulin. Sometimes we have to add insulin to these people as well, but we try to avoid insulin if at all possible in these type 2 diabetics because they tend to be insulin resistant. They tend to need very, very high doses of insulin to get the same effect that we see in a person with a type 1 diabetes. And in addition, I find, I don't know if you found this, that the insulin increases the appetite of these people.
They get hungry.
And
with all
the
that
one
insulin.
thing we don't want to do is make them hungrier because
Yeah.
we're trying to make them diet.
Right.
So I don't know if you had anything to add to that.
Oh,
but
no, it's definitely, well, you know, I guess there are two things that come to mind. Number one is there's two types of diabetes, but they're not evenly distributed in the population.
Absolutely.
I mean, most of, I think what we're talking about today is type 2 diabetes. 95% of people that have diabetes have this type 2.
Absolutely.
And it used to be called adult onset. Lots of kids are coming down with it now.
We actually are seeing some children with the type 2 diabetes, and there's actually a name for this. It's called maturity onset diabetes in the young. And this actually, there is a gene that predisposes people to this. So that you'll see in families. There are some families in the United States that have this gene, and when you test everybody in the family,
Test
because
everyone
very
in the family.
often they will have that.
Lifestyle changes and medication both can affect somebody with impaired glucose tolerance or diabetes. 20 million people with this impaired glucose tolerance or pre-diabetes, whatever, that's quite a bit. So if you can come up with something that's going to prevent these people from coming down with diabetes, that could have a huge effect. And there was this study where they actually took people with impaired glucose tolerance, the pre-diabetes, and sorted them out into 3 different groups. I love this study because it's very important. You already mentioned it.
Study.
You already mentioned it.
But I'll let you talk about it some more
Okay.
since you like it so much.
The first group of people, they did nothing. They just kept the usual medical care. Second group of people, they gave them a medication, metformin, which actually can help control the blood sugar in the body. The third one, though, they went a different route. They looked at lifestyle. And very modest goals. All they asked the people to do was to increase their level of activity just enough so that they would lose and modify their diet a bit, get on a better diet, increase the level of activity and the diet, just enough to lose about 5 to 7% of their body weight. So if somebody is 200 pounds, that's only losing 10 pounds. If they can just do these things enough to lose 10 pounds, they would be in this arm of the study. And what they found was pretty striking results. A number of the people that had just the usual medical care went on to develop diabetes, as expected. The people that took the medication, metformin, about a third of them, they decreased their risk, I should say. by about 30%. They decrease the risk of going on to diabetes by about 30%.
Right.
But the people that
modified
their lifestyle, kind of like turned around the things that got them to this point, that lost maybe about 5 to 7 pounds, that when we say exercise, not really so much exercise, just increasing your level of activity enough so that they were walking maybe for 30 minutes a day, 5 days a week.
Mm-hmm.
That's like watching one short TV show a day. Instead of doing that, just going out and walking or doing some increased level of activity and modifying your diet was almost twice as effective. 58% of those people in that.
And when we're talking about increasing the level of activity, one thing we have to be very careful of is a lot of people decide, okay, I'm taking charge of my diabetes today, and this is what I'm going to do, and I'm going to start jogging 3 miles tomorrow. And that is not the way to do it. I think you'll agree with me. We want to build up to it slowly, because especially even people who have this pre-diabetes or this impaired glucose tolerance, they could already have been developing some degree of vascular compromise, and by just going out and exercising like this, it may be too taxing on their heart. We don't want to send them out to have a heart attack. We want them to take it slowly and slowly build up to it as their body is able to tolerate it.
Well, just like those foot ulcers are silent, people don't even know they have them, can often have silent heart disease, as you're saying, so that they can suffer a heart attack and they won't even know it until their heart is just deteriorating to the point of where it's not functioning well. But I tell them the same thing, and the reason is, you go out, you join a gym, you get up on the treadmill or do something like that. Next day you're going to be achy. You're not going to want to go back. You spent a couple of $100s. And there's
then
much
they want
better
the doctor
ways.
to write a note saying why they can't go back to the gym anymore. So they got to get their money refunded.
Right. So the number one thing to do is to go see the doctor. Go see your doctor. Make sure that you're okay to increase your level of activity.
Absolutely, and very often I think it's very prudent medical care to do a stress test on these people before they're ready to start exercising. Because, let's make sure that they don't have any underlying heart disease before they get started with their exercise program. A baseline cardiogram would probably not be enough for this.
Probably not. You want to stress the
We
heart.
would make sure there's no vascular compromise with the exercise.
Mm-hmm.
When we were talking about the two different types of diabetes, I just wanted to get in briefly into about some of the symptoms that the patients present with the two types of diabetes. Generally, with type 1 diabetes, the patients initially would present with the symptoms of the elevated blood glucose. And the symptoms would be that the patients would be very thirsty, first of all. They feel very thirsty and they're drinking all day long. And then what happens? They have polyuria, they have urinary frequency. These patients very often will come in just complaining of the urinary frequency, thinking they have a urinary tract infection.
Urinating.
They're urinating nonstop. And this is really not just because they're drinking more water, but because the glucose that's in their bloodstream is going through their kidneys, going into their bladder and out in the urine, and it's drawing water with it. And they're having urinary frequency, they're having very excessive thirst. They're also having an excessive craving for food, interestingly. But even though they have this craving for food and they're eating, especially sweets they crave, they very often have weight loss. And the reason is that these type 1 diabetics, remember I said, do not have insulin. Their pancreas is not making insulin. So what happens? They take this sugar into their bloodstream, it's circulating in the bloodstream, and it can't get into any of the target organs that it's supposed to get into. These being the liver and the muscle.
The muscles.
And it's not getting in there. And essentially these people are starving. Okay? So they feel fatigue and they're actually losing weight. Okay? Now, when we turn to type 2 diabetes, we very often do not get the symptoms early on. We're getting symptoms of all the consequences of the elevated blood glucose because, as we said earlier, they've had the elevated glucose for a few years already before they're being diagnosed. So these are the ones that were presenting with all those infections, those skin infections, the gum infections. The women get very frequent vaginal infections. They may present with kidney dysfunction, which the doctor just picks up on a routine blood test and finds that their kidneys are not functioning the way they should be. Many of these patients complain of blurred vision. Not even necessarily because of, as I said, the changes in the retina with the blood vessel changes, but just changes in the lens. The different levels of blood glucose change the visual acuity, and they always feel like they need their glasses changed, and they just can't get the right prescription for their glasses. These people can complain of pain or cramps in their legs, their arms, their feet, their fingers. They may notice, they may just tell us, you know something, I've got these cuts and these bruises, they're just not healing the way they used to.
We hope that you find this program both interesting and informative. Please know that we at Franklin are always here to answer any questions you may have and to provide you with the finest medical services available. Thank you.
Hi, I'm Dr. Ellen Miller. I am the Vice President of Academic Affairs and the Assistant Medical Director at Franklin Hospital Medical Center, and I'm in private practice in internal medicine and endocrinology.
I'm Dr. Patrick Corcoran. I'm Director of Rehabilitation in the Franklin Hospital Medical Center and also the Medical Director of the Extended Care Division, which includes a subacute rehabilitation program. Dr. Miller, perhaps you could say a few words about the problems of diabetes.
When we turn to type 2 diabetes, we very often do not get the symptoms early on. We're getting symptoms of all the consequences of the elevated blood glucose because, as we said earlier, they've had the elevated glucose for a few years already before they're being diagnosed. So these are the ones that were presenting with all those infections, those skin infections, the gum infections. The women get very frequent vaginal infections. They get yeast infections. They may present with kidney dysfunction, which the doctor just picks up on a routine blood test and finds that their kidneys are not functioning the way they should be. Many of these patients complain of blurred vision. Not even necessarily because of, as I said, the changes in the retina with the blood vessel changes, but just changes in the lens. The different levels of blood glucose change the visual acuity, and they always feel like they need their glasses changed, and they just can't get the right prescription for their glasses. These people can complain of pain or cramps in their legs, their arms, their feet, their fingers. They may notice, they may just tell us, you know something, I've got these cuts and these bruises, they're just not healing the way they used to. Some of them present with GI disturbances, with anything from they don't feel like they're digesting their food well, they can present with nausea, vomiting, constipation, diarrhea, any non-specific gastrointestinal symptoms they can present with. The men sometimes present with impotence, and this is unfortunately another long-term effect of vascular compromise, that the blood vessels are also not feeding that part of the body correctly either. And then, of course, it's very bad when we have them presenting with a cardiovascular disease. They present the first time with a heart attack, they come in, and on the blood sugar we notice that they have diabetes.
This gets into things that people can do. First of all, seeing the doctor on a regular basis, and the doctor thinking about diabetes, checking the blood sugar and all. Even in somebody who does not have a history of diabetes, so there's no reason to think about it. When you get to a certain age, the doctor should be, raising the question probably, especially if you're a bit overweight.
Most physicians, however, even all the primary care physicians, at least once a year, if the patient presents to them once a year, they'll do a routine blood screening. They'll usually do a fasting blood screening, and it has a glucose level in it. It also usually tests their kidney function, basic kidney function, and liver function, and everything else. So if they go to the doctor at least once a year and they have a blood test, it usually will be picked up then.
And that's if they go to the doctor.
How many women don't go to the doctor? They've had all their children, and they don't go back to the doctor after that for many years. In normal glucose metabolism, a rise in the blood sugar signals the pancreas to start producing insulin. Now, I've alluded to this already when I've said that in diabetes, we don't always have enough insulin. And what the insulin's job is to lower the level of glucose in the blood. Now, how does it lower the level of glucose in the blood? It allows the sugar to enter the other cells in the body, get them out of the bloodstream, and it puts it predominantly into the fat, and that's where it's converted into fuel that's used for the body's metabolism. It also turns off the production of glucose from the liver. Okay, the liver stores glucose in the form of glycogen. Okay, so when we have insulin around, it stimulates the liver to take that glucose and convert it into the storage form, the glycogen. Sure. When the insulin is not there, the liver breaks down the glycogen and uses it for glucose, for energy. And that's exactly what happens in diabetes. In diabetes, we have insufficient levels or a lack of insulin that upsets this normal glucose metabolism. Now, due to the inadequate insulin levels, it's much more difficult for glucose to enter the fat and the muscle cells, and it begins to build up in the bloodstream. And what is that? That's the signal for the liver to break down the glycogen and start releasing more glucose into the bloodstream. These cells compensate for a lack of glucose, I'm talking about the fat cells and the muscle cells, by switching to alternate sources of fuel. Okay, so what do they do for fuel? First, the fat is broken down into fatty acids, and the muscle protein gets broken down into amino acids. And then the liver takes all this stuff up and makes it into more glucose. So we have gobs and gobs of glucose, but unfortunately, it's not getting into any of the cells, and the metabolism starts falling down. And that's why in type 1 diabetes, very often we'll see the patients will be fatigued because they don't have any energy. And they start losing weight because they're breaking down everything, their muscle and their fat, just to use it for energy. This results in higher and higher blood glucose levels. It results in the glucose spilling over into the urine and drawing all the water with it, like we said that before. And then when all the water goes out in the urine, they're left with very little water in the bloodstream, and the patients become dehydrated. They show a dehydration. And in type 1 diabetes, these patients develop a condition called diabetic, and this can be a life-threatening condition. Generally, what stirs it off is they've got this diabetes smoldering a little bit. It hasn't been diagnosed. And then sometimes they'll get a virus. They'll get a small illness or something. They won't eat that well or something. And then it just puts it into this, and it goes in a cycle, and the cycle just doesn't break until someone makes that diagnosis and gives them the insulin. In type 2 diabetics, they don't develop ketoacidosis because they have some insulin. They just don't have enough for their body. And so these patients develop a condition called a hyperosmolar syndrome. And in these patients, they also get rather dehydrated as well. However, they don't get ketotic like the type 1 diabetics, but they can also die from this condition, and they have to be treated aggressively. And the interesting thing is they don't need tons of insulin like the type 1 diabetics. They need gobs and gobs of water. They need to be hydrated up. It's not enough to just give them water by mouth and tell them drink a bunch of 8-ounce glasses of water. These people must be admitted to the hospital. We put in an intravenous and we load them up with fluids. We have to do it very carefully because, again, these patients are a little bit older. They've probably had their diabetes for a while back and they haven't been diagnosed. And they may have some underlying heart disease. We don't want to tax the heart too much and throw them into congestive heart failure. So this is a little tricky to manage, and we have to manage these patients very, very closely. I can't stress enough, and you don't stress enough, that they must watch their diet. Nutrition is of the utmost importance in both type 1 as well as type 2 diabetics. The exercise, again, is tremendously important, and again, just have to stress, don't just go out there and run 3 miles a day. Make sure you get checked out by the doctor before you start your aggressive exercise program. And then in the type 2 diabetics, we like to go then to the oral medications if we can't control the sugar well enough with just the diet and exercise alone. And when we talk about the oral medications, they have names, which I'm going to go through them with you. First by the generic names and by the groups of drugs they are, and then we'll talk about some of the brand names because I think the patients will recognize them by the brand names rather than by their generic names. Well, as far as the oral medications for diabetes, we really have two different ways that the drugs can work, and that's the way I'm going to classify them. The first are the drugs that will augment the patient's supply of insulin, okay? They stimulate the pancreas to release more insulin, okay? And there are two types of drugs in this category. The first are the sulfonylureas. Sulfonylureas are the original oral drugs, the original pills that we took by mouth for diabetes, and they've really graduated over the years so that we have new second and third generation sulfonylureas, which I'm going to mention briefly by name in a couple of minutes. The second type of drug that augments the patient's supply of insulin are the Meglitinides, and that's just a class of drugs, and then we'll come back to that in a minute. Now, the second group of drugs that we're going to talk about are the ones that enhance the effectiveness of insulin. These take the body's insulin that's already being produced by the pancreas and they improve the way it works at the level of the liver, the fat, and the muscle. Okay? And they include three different types of drugs. The first of these are called the biguanides. The second are the alpha-1 glucosidase inhibitors. And the third are thiazolidine diones. Those are a mouthful, aren't they? Well, let's look at these a little bit more closely. First of all, when we talk about the drugs that increase the release of insulin from the pancreas, we're talking first about the sulfonylureas. And I'm sure we've all heard about diabetes. Diabetes has been out there for many, many years. These were the first drugs. When I first became an endocrinologist, this was what we had available to us, and it was pretty much the only drug. Subsequently, we got Micronase. We got the glucotrol family, glucotrol, and then we got the glucotrol XL, which could be given once a day. Most of these drugs before that had to be given twice a day. Then we got a glinase, we've got diabeta, and we've got Amaryl. So these are all drugs that work in similar ways, and some of them have advantages over other ones in terms of when they're taken in the day and whether they're once a day or twice a day. But otherwise, they work in similar ways. The other drugs that also lower blood glucose by stimulating the release of insulin from the pancreas are the Meglitinides. And these drugs are taken with meals. They almost act like a short-acting insulin that you would take right before a meal. And what they do is you take it right before the meal, 3 times a day before breakfast, lunch, and dinner. These drugs would include Prandin and Starlix are the two drugs in this class. And the important thing to remember about this is they really work at releasing insulin from the pancreas, so you don't take them if you don't eat a meal. Okay? Because your blood sugar level can drop very low if you take the drug and you don't take the meal. So these are the things you want to take right before you eat the meal, and you want to make sure you're actually going to be having the meal in front of you before you take it, not that you're anticipating that maybe you're going to eat a meal. Now let's turn to the drugs that work on the end organs, that improve the insulin sensitivity. And the one that improves the insulin sensitivity at the level of the liver is the biguanides. And there's one drug in this class that you've been mentioning before that was involved in these drug studies, and this is called metformin. Metformin does not stimulate the release of insulin from the pancreas. It specifically works at the level of the liver so that it increases the glucose going back up to the storage form, the glycogen, and it decreases the glycogen being the glucose itself. Okay, so that's a drug. In addition, some people are hearing more about metformin. It's being used actually in some other conditions. You may have heard of polycystic ovary syndrome. And these are young women who have a hormonal imbalance that causes them actually very often to be obese. It also causes problems with ovulation and their menstrual periods, and it causes a male pattern of hair growth. But interestingly, they do have a problem with their insulin receptor capability, and they seem to respond as well to metformin, even though it's not an official use for the drug. But that's an interesting use that we are using it for. Now when we turn to the alpha-1 glucosidase inhibitors, these actually delay the digestion and the absorption of the carbohydrates from the intestines. Now, don't get too excited about this. I can see what you're thinking already. You're thinking you can take this pill and then you can eat whatever garbage you want and nothing's going to get absorbed. You will not be a happy camper if you do that because it's going to go right through you and you're not going to feel too good, okay? The drugs in this class are called Precoce and Glycet. These are also drugs that would be taken before the meals, okay, because they do affect the absorption from the intestines. And you can use these drugs alone, or sometimes these are used in combination with the sulfonylurea. And then lastly, in the oral agents, we have the thiazolidine diones. And these also increase the body's sensitivity to insulin. These work predominantly at the fat and at the muscle. Also have somewhat of an effect at the level as well as the liver. And these drugs, the drugs in this class, include Actose and Avandia. These have the advantage of being able to be taken only once a day. They can be taken with or without meals. And they can be used alone or they can be used in combination with any other medicines that we've been. And actually, these are also used sometimes with insulin in some of the type 2 diabetics that need additional control.
It's amazing how many medications they have come up with.
It's because it's such a disease that is so prevalent in the population and has such devastating consequences that we had to develop medications for it. And this isn't the end of the story. Dr. Corcoran, they are still doing studies on a regular basis. They're always ongoing, looking for new and better treatments for our diabetic patients.
One of the best treatments, I should say. Now, medications, one of the best treatments, though, remains increasing your activity level and controlling your diet. In that one study I mentioned before, it's probably twice as effective in preventing the progression of diabetes. What about insulin, though?
In the type 1 diabetics, as I said, they all require insulin. And the type 2 diabetics sometimes require insulin as well if we can't get good enough control with the pills that we're giving them. The insulin has typically been available to us as an injectable. It cannot be taken, it has not been able to be given orally up to this point because it's broken down by the acid in the stomach and our enzymes in our stomach, so you can't just take a pill of insulin. The insulin has been given by injections, and we've made great advances with the insulin injections as well. We initially just had two types of insulin. We had NPH, which was the longer acting insulin lasting about 8 hours. It was peaking at about 8 hours. And then we had some regular insulin that we were giving the patient a second injection with regular insulin that would peak maybe at 4 hours. So they would be taking a combination of these before breakfast and maybe again before lunch, before dinner. We would be taking different times of the day, multiple doses of insulin.
Trying to mimic what the pancreas.
Of course, how do we know what dose to give? We have these patients checking their blood sugar regularly. We have them do home blood glucose monitoring. They stick their finger and they check their blood, gauge their next dose of insulin based on this. as insulin was progressing through the years, there were some preparations made that made the combo for them. There was a 70-30 preparation that made 70% of it was NPH, 30% could be regular. Then we've come a long way over the years. Probably the state of the art right now for injectable insulin is the insulin pump. We have an insulin pump that can give a constant low dose of insulin throughout the day, again mimicking the pancreas, and then prior to meals having the patient pulse themselves very easily. They wear this little instrument that is about the size of a beeper. They wear it on their belt. It's got a little catheter it's put under their skin, and it just stays there, and they, based on their blood sugar levels, can just pulse the insulin prior to the meals. Some of the other things that are coming up along the way that are in research development now are actually inhaled insulin. We're looking for other alternatives that might prevent the need for injecting, because especially with our young children with insulin, who are on insulin with type 1 diabetes, it's very hard for them to get adjusted to the injections, and we're trying to look for an alternative for them.
But it is very hard for a parent and a child to be doing that. Well, the finger sticking and then the injecting. It gets back to, though, if lifestyle, if diet and exercise is what brought us to this epidemic of being obese and diabetes, why can't we just reverse it? What are the barriers to people just exercising a little bit more and changing their diet? I know one of them, I believe, is that diabetes early on is asymptomatic. I mean, we're talking about all the different body organs, the vision, the nervous system, the blood supply, the immune system. None of these things has a dramatic effect. If you come down with pneumonia, you have a temperature. If you have a kidney stone, you have pain. Diabetes, you don't have anything for quite a while that damage is being done.
And that's why many people who wait until they get their first scare to change their lifestyle are not getting that scare early enough to diabetes.
And until something happens, though, it's still hard to appreciate. 90% of people with diabetes agree that diet is important. Only about 2/3, though, actually state that they're following guidelines.
Most of my diabetics agree that it's important, but what are they doing about it? They're not all doing something about it.
No, they're not doing something about it. They can agree up and down, left and right,
Absolutely.
but they're not doing anything about it. Some people say I'm too busy to do something about it. And I wonder, first of all, there are so many advantages to just doing these things, losing a couple of pounds weight. If you lose 15 pounds of weight, that's 15 less pounds you have to carry around. And I try to have people envision walking around with a gallon of milk in each arm, because that's about 15, 16 pounds. And, just getting up out of a chair.
If they like that, they can go to Walbab's for
2 gallons of milk. That's 15 pounds. And if you can lose that, that's chucking away.
Absolutely.
That. So that's important. You feel so much better. If you lose weight and you have some arthritis in the knee, 15 pounds is 15 pounds less weight on that knee. Your cholesterol ratio is better. Your blood pressure is better. You just feel better.
They'll correct everything in their body. And once patients start a diet and exercise program, don't they always tell you they feel better?
They feel better.
They feel better. They have a better sense of well-being. Everything feels better. Everything is going better.
So before...
Their blood pressure is better, everything.
Before, while they were saying they're too busy, now they feel like they have time to do things because they're so much more energetic and all.
Absolutely.
It's so much less tired. I hate to exercise. I tell people, well, if your idea of exercising for this program is to go and join a gym and lift weights, get on a treadmill, Stairmaster and all, then don't exercise. What you have to do is increase your activity level. Two things really, increase your activity level and decrease your inactivity level.
Absolutely.
They do go hand in hand.
Absolutely.
But by increasing your activity level, it doesn't necessarily mean, again, joining a gym or going out and running. Just because you could run a mile in 5 minutes when you're in high school, that's not your goal at this point.
Absolutely.
Your goal is...
Some of my patients, I just tell them to get a dog.
Maybe you'll miss a half-an-hour TV show, but you'll be so much better off. Or instead of taking the car, carrying the groceries around, get off the bus one stop earlier. Gardening. Mow your own lawn with a push mower. Forget intensity right off the bat, because if you're thinking about, well, I have to run a mile in 5 minutes like I used to, that's not your goal. Your goal is, if walking from here to there is exertion for you, that's exercise for you. And that will have a good benefit in decreasing your blood pressure, controlling your glucose. This is especially important with kids. We don't have to really get kids to be more active, and just being on a soccer team on a weekend isn't really it. If we could get them to be less inactive, by not watching as many video games and watching TV, if we can just get them away from the TV, tell your son or daughter, you know what? You can watch that TV show if you go out and play for an hour. It's a 2-hour TV show. You go out and play for 2 hours first or something. You don't. If people say I don't have big blocks of time, well, you don't need big blocks of time. All you really need is 30 minutes of accumulated activity, and if that means walking fast for 10 minutes 3 times a day for those 5 days, that's it. I never stick to it. I never seem to improve. You will improve. It doesn't have to be losing 50 pounds. Family history. Does that play into whether or not somebody should be concerned with diabetes?
In type 2 diabetes, there's a definite genetic component. If a patient's mother or father had diabetes, we look more aggressively in the children, and especially as they approach middle age, it comes out more. We also see diabetes if a woman has had diabetes during pregnancy, she's more likely, even after the pregnancy is over, very often the diabetes resolves, but then later in life it comes back to haunt them again. So that's where we're looking for. We want to aggressively actually look for these people. There also is a genetic component thought with type 1 diabetes, but it's not quite the same as with the type 2 diabetes.
It's very strong with type 2 diabetes. If you go to the American Diabetes Association website, that's org, you can actually look at a questionnaire, and one of the questions is, does somebody in your family have diabetes?
Oh, absolutely, because that's why we take that in the family history,
Yep.
and those are the patients we want to go looking for. And when we are looking for it, we generally check not just a fasting blood sugar on these patients in the office. What we do is we tell them, go out and eat your regular breakfast, your usual breakfast, and come back to the office 2 hours later and let me recheck your sugar. Because then we can see how their insulin is handling their blood sugar, and that'll sometimes pick up these early diabetics for us.
Right, so you're not just looking at the fasting, you want to see what happens when they have a dose of glucose, sugar,
A sugar
how
dose,
their body responds to it.
absolutely, and then we want to see how their body responds to it.
Okay.
What do you think about your patients who come in and say, you know something, I just cannot follow this diet all the time, 24/7. I got to go out. It's my birthday. I want to go out. I want to have an ice cream sundae. Dripping with the goo.
Nobody's saying that you have to give up your life, all the pleasures in life. But you didn't get diabetes by having a super duper ice cream sundae on your birthday once a year. You gave it because of your lifestyle the other 364 days a year. If you can now, on that one day a year, go crazy, but really basically control your diet, increase your activity level the rest of the year, you'll be okay. Again, you just have to keep an eye on your blood sugar, especially if you're taking insulin. You'll probably have to take a little more insulin. And these guidelines go into if you're exercising, just like if you're going to splurge with ice cream and sugar, if you're going to go out and all of a sudden start exercising, you have to keep an eye on your blood sugar and insulin.
Oh, absolutely. One of the most important things here is not just having beautiful numbers on a blood test. It's a lifestyle also. They have to make lifestyle changes, but they have to live. And it's okay if they occasionally have a dietary indiscretion. They're going to cover it. That's one dietary indiscretion is not going to raise that hemoglobin A1C for the 3 months all that much.
The test is not that sensitive that, 3 weeks ago.
And that one ice cream sundae once or twice a year is not going to cause all the long-term adverse events that we see.
Knowing that A1C, though, is also critically important because while people have a hard time understanding all the complications from diabetes, that A1C kind of sums it all up in one simple number.
Oh, absolutely.
And for every 1 point that A1C goes up, say from 7 to 8%, that increases your risk of cardiovascular disease and dying from a heart attack or whatever, somewhere about 25%.
I let my patient know their hemoglobin A1C every 3 months. I call them, I tell them their number, and if it goes, I get upset if it goes from 7.1 to 7.3.
That's significant.
That is a significant change, and I don't want to see that. I want to see it go from 7.1 to 6.9 instead.
And that's significant too. That can have a
huge,
because every year that you put off the complications of diabetes or having diabetes is one more year of freedom. Of being able to walk around without the amputation, of being able to drive into the night, reading your favorite books, gardening, whatever. So if you can postpone it even by a year, that's another year of freedom.
We have spent some time with you providing valuable information about diabetes. And we hope that the discussion that Dr. Corcoran and I have shared with you will be useful to you in your daily lives. Thank you very much for your attention.
We hope that you find this program both interesting and informative. Please know that we at Franklin are always here to answer any questions you may have and to provide you with the finest medical services available. Thank you.